We have a very international group. You can look at the bios in the program. That's one of my ways of actually not spending a lot of time introducing everyone, but rather hearing from them, which I think is more interesting. In preparation for this panel, we had a little meeting, and I tried to figure out for each of our panelists what was the main thing they wanted to get out. So again, as a facilitator, my goal is to make sure that we don't get distracted too much and each panelist gets to say their main thing. The goal of this panel is to discuss how do we assess care. And I think as a first round, I'm going to ask each one to very briefly indicate sort of their point of view, how they come to the issue of assessment of care, what is their perspective on that. And before we talk about assessment, I would like to hear from each of them, what do you think care is, right? If you're going to assess care, let's start by understanding what is care for you. So since we already heard way too much from Paul, we're going to start. We're going to start with Francis.
Hi, am I using the?
Oh, you
is
are
how it
using
works.
that one.
Oh,
yes,
thank you. So for me, care is about caring. So it's about having relationships with patients that come to see us. And having those trusted relationships and continuity over time. So I'm a family physician or general practitioner, so that's kind of what I've been taught to do all my life, and something I think is really important. So obviously we want care to be one that helps people to be as well as they can be given their personal circumstances, and we want to improve outcomes of care and make sure we're providing quality of care in terms of the appropriate treatments and appropriate management, and helping people to manage, but also that we're meeting people's goals and that we're understanding. So you can be so fixated on guidelines and things, and we do want to have evidence-based medicine and do the best evidence, but it's about thinking about what people's goals are, and when we give advice, do people agree with the advice or buy into that advice? I think it's a reasonable thing for them to do. And then are they able to do those things that we're asking them to do? And if not, how do we help them to self-manage and self-care? And I think too often we think about outcomes just in terms of mortality or hospitalizations, which are important, but perhaps not enough about functional abilities and well-being and what matters to patients.
Excellent. So care as a relationship directed at helping people get better outcomes that matter to them, either directly or by supporting their self-management. Did I summarize that? Very good. Excellent. That's my effort at mansplaining. Paola.
So good morning. I am Paola. I am MS patient expert. For me, care involves, in addition to what you just said, involves humanity. And that means, and something also very important is information. Which words are we choosing when you are communicating with the patient? And for example, we talked, Paul, about, and yesterday also about the American community, speaking Spanish, speaking in English, or me, I'm Mexican, I forgot to mention I'm Mexican, me being a foreign in France, I live in France. Sometimes the language is not appropriate to your patient because they don't not have the knowledge, they don't know, they don't understand, we don't understand. So which word you are choosing to communicate your message? As a patient, care is being sure that the message was delivered properly. What I am saying is not necessarily what the other is listening. And the amazing picture Paul mentioned about the blah, 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 stuff thing, is exactly something I have experienced several times in my life. There is a moment a patient just stops hearing what they are saying, and it just becomes blah, 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 blah. In my case, I will start dreaming about pizza. So it is important. Care is information, good information, and humanity. There is a person who is in front of you. If I will be received by a neurologist that is super stressed, is counting the minutes, and he just wants to deliver because he has a very busy agenda, I don't care. Because this is my time, this is my moment. I want you 1000% with me in this moment, and everything will be about me. So care is understanding that you have a human in front of you, and that is something that is very important for me.
Excellent. So it's your emphasis has been on information, understanding, and understanding towards helping people self-care. Is that the main? Excellent. Guru,
Thank you, and good morning.
get closer, get really close to the microphone, and it really helps.
Closer to the microphone, thank you. So my name is Bernsten. I'm from Norway. I work in the Norwegian Center for E-Health Research, and I've been working on quality of care seen from a patient perspective for the last 20 years. So I've done a few studies where I've asked patients, how do we assess care? I've asked them, I've gone through their notes, and then I've gone to ask them what happened in your care and what was important, and was it a good or a bad thing? And it's quite illuminating both where I started. Maybe the point where I started is as important to notice as where we ended up. So I started thinking that it would be that I'd be looking at care events, and that the series of each event would have a good or a bad kind of view, and then the whole journey would be a kind of a summarization of each event. And I realized quite fast that no, patients don't look at events per se. Most events are nice. Most events, they appreciate what it's all about. They feel that professionals are mainly both compassionate, that they understand what they're doing. They're very, very appreciative of their care. But then somewhere in that journey, something happens that causes a break. And most of the care is fine, but if that break disrupts the journey, then that is what matters. So if we keep on assessing care events and not the journey, then we're missing out on what patients, at least the patients I talked to, found important.
So, Brooks, hold on. Let me interrupt you for a second before you get to that. So, because you jumped to assessment, but I wanted to, if you could reflect a little bit on what is this care that you speak of. Yeah.
I'm coming to that.
Oh,
I'm
but I
coming
needed
to
to-
that
yeah,
because what I want to say is that what the patients told me care is about. And so one thing, they assess the journey. They don't assess the events. They look at the whole journey. And it's when something happens that threatens what matters to them over, in their lives. That's when they say, this was bad. This didn't work for me. And that's where trust gets either forged or broken. So it's when you get listened to and the care is addresses what matters to you, and you feel that you're supported in making care fit into your life, that's when patients say, this is a good patient journey. But if something threatens your goals and that is not taken into account and it doesn't fit into your life, and the typical challenges are I'm not being seen and heard. What matters to me isn't being taken into account. This is a checkbox version of listening to what matters to me. That's when they say, no, I don't trust this. I'm not going to do this. I'm going to do it my way. And that's where you get the non-adherence. And actually, patients can veto everything we do. So good care is when we are able to connect in that way where we understand what matters to this person in their context, and we are able to create care that addresses their concerns in what matters in their lives.
So we're getting a bit of an
That's good care.
Yeah, so we're getting a bit of an idea, thank you, a bit of an idea that care is a journey, that it involves picking up what is the matter, what is the problem, and which requires seeing the person, understanding the person, listening to the person, and then figuring out what to do about it to help. over time. And part of that help includes developing a common understanding with clarity that allows the patient to understand what's going on and participate in that process of care over time.
And across all the deliverers of care.
Or all the?
Across all those who deliver care. Because in a
across all the
patient
participants,
journey,
yeah.
there's not just one professional. There are many professionals, and they do not have the opportunity to talk together. So I've become very concerned with how do we make the continuity of care, if you can't make it with personal continuity, which often is not possible, how can we use information systems to create support for that continuity?
Okay, so that's something we have to come back to see when you talk about continuity. Is it continuity of information, or what kind of continuity we're talking about? Paul, this was very comprehensive and very compelling. Anything to add?
I feel completely underqualified to that care, but I can give you my underqualified opinion. So I think on a whole, it's about valuing and honoring an informed person's preferences for living well, just as a broad sweep, and sort of for the person in the room, understanding this patient's needs, not solely through a medical lens, and providing them, I think it was, I don't know, it was Amelie who said it, but providing the care they want and no more, and the care they need and no less. But I think the important thing to add is doing this while trying to avoid harm, be it physical, psychological, financial. So I think that's my thoughts on what care is.
Mm-hmm. So I think we have we kind of get a sense where the panel is in relation to what care is. I suspect that every time we define care, there's a bunch of things that are left assumed. And the fundamental assumption here is that if a person comes to a clinician for care, it's because they want their situation to get better, right? And that they want at the end of the interaction, either the one visit, if it's an emergency room, for instance, or the longitudinal relationship, is that they want that to actually make a positive difference in the way their situation is playing out, right? They want change for the better.
Can I comment something?
Absolutely.
I like you saying they want your situation to go better. That happens most of the time, but not when you have MS. They just inform you that this is going to be just worse and worse. Well, that's what the patient hears. What we want, or at least me as an MS patient, we just want the things to stay as they are. We don't want to get worse. So sometimes your goal cannot be doing better, but if things can stay as they are now, that will be good. So how can you help me to stay as beautiful as I am today?
So if somebody can make a difference so that instead of having a decline in the situation or multiple recurrences, if things are stable and good, that will be a difference that would be worth making.
Would be great.
And that actually harps to the issue that was raised about what is important, what matters to the patient. Francis and Gru.
Yeah, so I think adding to that, I think that's very true. I think you also have the situation where people do have irreversibly progressive conditions, not even relapsing and remitting, and palliative care situations where you know that people's life expectancy is shortened and that they are going to deteriorate. And so part of that caring is helping them on that journey to be as good as they can be and as supported as they can be and to be cared for as well as they would wish to be.
Yeah, so making this a difference, a positive difference in the situation of somebody that's not necessarily making it good or desirable, because that's the other part, is that nobody desires to be sick or to stay sick or to be dying. Gru.
So I was also going to comment, same as Paola, on whether a patient wants, the patient is here because they want to be better. That's a statement. And then the patients that I've been working most with are patients with long-term conditions where things might be, in fluctuation, but often it's quite stable. They're well aware of their condition and what's available. And I believe that I see the other way around. I'm here to figure out what you can offer me. Is there anything new on the table that can be useful to me? And if there's not, then I don't really need to spend time here. I don't want to spend my time in healthcare. Also, there is situations where the relationship and where the how you connect is really, really critical, because you're in some vulnerable situation often where things are getting worse, or and that in that setting the relationship is super important. But then in chronic care, there's a lot of time where I know what this is, I know what I need, I'm the expert here. I don't really need that relationship conversation at this moment. What I want is for you to give me my prescriptions, give me my this, that, and the other thing that I know that I need, and then I don't want to be here. I want to be in my life. I don't want to be in healthcare. And sometimes I feel that in our concern to be so sensitive about what matters, and we forget that sometimes what matters is to not be in healthcare, to not be a patient.
Yeah.
So it varies. It varies with person, but it also varies for the person within the context of their condition.
Yeah, I really have to, I usually imagine that my patients want to spend as much time with me as they can, and that's usually not the case. Paul?
So it just, as you're hearing, I think it's more, I think your statement was a little bit too broad and vague in terms of what care is, because I think there's probably, there's preventative care, and there's acute care, there's chronic care, and they all mean different things. And I guess if you think of care, then it equates to like an action or behavior. We heard about behaviors yesterday, and there's also a cognition for the need of care. Maybe a patient's coming and they don't perceive there's actually a need for care. They're coming because it's their annual wellness visit. They're like, well, I guess I have to go and do this thing. It's an obligation as opposed to care for them.
Yeah, I think I was not summarizing broadly. I was just adding to the definitions that sometimes it gets lost, that the reason people come to care is to get better. Now, what we are hearing is different definitions of better, right? And so different people in different circumstances define better in different ways, right? But nobody wants to go to healthcare to actually get worse. My goodness, I didn't expect that to be that controversial.
I think yes. I think yes.
Would you
people
wait until
generally-
what I have? I mean, I have more stuff. Hey, go ahead. Yeah.
Yeah, probably they don't come to get worse. Yeah,
Yes, yeah.
I think we can agree on that. But I think also we seem to be thinking about people with a single condition, and we know that actually most people now have multiple chronic conditions and also have various social and complex lives in the background in which they're trying to manage and juggle those conditions. And as you rightly say, there are some people who are just fine, so don't want to be near people, but there's a lot of people whose people will vary in their capacity to manage with different types of complexity and challenges. And it's about caring, I guess, it's about recognizing those differences and being able to tailor or personalize the care to meet those very different needs that will be presented to you.
Yeah, and in chronic condition, I usually tell my patients the most common outcome is disappointment, right? Because you expect things to go well and sometimes they don't. And so care is also creating the space to recover from that disappointment and keep going, right? So there are multiple aspects of making it better. Paola, yes.
About disappointment, I want to mention the other side. Paul, you were mentioning it. Sometimes we, as patients, we have nothing to say to the doctor. I am feeling the same way I was feeling the last year. So that happened to me this year. And my neurologist said, okay, that's great. So that's a moment, let's say, to celebrate. So care is also like, okay, it's great that you have not, you are not doing worse or you are doing the same as last year. That's amazing. Now, instead of seeing you twice a year, I'm going to start seeing you once a year. That's a big celebration because then that's a good news. And I think, as you were mentioning, Gro, that's a moment when then the consultation will change. The attitude from the two parts will start like, okay, we can relax for the 10 minutes, the minutes I was considering to allow to you. We can maybe use less, maybe using differently, let's talk about the favorite topic of French people, the weather and the holidays. Let's talk about something other thing than health. And this is something that is also care, and it's also it's a good news. So care is also celebrating these tiny little moments that we can have with our patients.
So that all sounds great. If care is to make the situation of the patient better, defined in a number of ways, can we go around the table very briefly? In your environment, who gets to determine what is better? So not who should, but who gets to determine what is. So if care is to make the patient better, I'm sorry if it's too big, who gets to define in your setting what is better? You will start with, do you know the answer to that question on your end, Paul? And we can just come back to me.
So I guess that, technically there's different metrics.
No, but who gets to who?
Well, and that's the problem, that there's more than one person determines.
But,
So is that person, okay, so like the health system could be determined.
What's that?
The person who's checking the box to say that we have met this target for our care this month. So we have more people managing their diabetes. above
And
a
that's
certain
defined
threshold.
at the individual patient level?
I think they check it at an individual patient level and sum it up and then get reimbursed.
So for the population that
So
manage.
that's one level, but then there's also the patient level where they report like what was their experience, and that's also impacting sort of.
So like the satisfaction with the visit and,
Yeah.
okay. Grow in your environment, who gets to determine what's better care?
Oh, I believe that in my environment, it's clearly the system / the professionals that get to decide.
And who's the system?
The system is a system owner. It's a word that I struggle with. System owner, decision maker, whoever makes the structures and the organization that allows us to have a care system.
And
that
in,
a frontline
in Norway,
person-
is the who's?
in Norway, that would be the Ministry of Health.
And does the Ministry of Health follow a sort of democratic, do they have like all the Norwegians get together, well, I don't think Norwegians get together, but all the Norwegians get together and decide like, yeah, we think that's good care, or who decides?
Well, most system owners, including the Norwegian Ministry of Health, they look at system metrics that are we providing the best health at the population level?
At the population level.
Right? And is it sustainable? Because they're concerned with costs. And they should be. Sustainable care is care that doesn't threaten, that all our resources goes into healthcare. That can't be in a society. And then the second voice is the professional voice, which is concerned with evidence-based guidelines, and are we meeting, mortality rates, all of those things that professionals like to measure that are linked to our guidelines. And then, of course, there's a tiny little bit that is about patient experience. I can't see that in our system that it carries much weight. Mm-hmm. But I think those are the three important voices, though. The professionals, that's a legitimate voice. The system, that's a legitimate voice. And, of course, the patient. It's the patients it's all about.
Yeah, but that's a should that necessarily is an is, right? So, Paola, do you have opinion on who gets to decide what's better care in reality?
I cannot go against what you just said, because that's the truth. Me as a patient, I honestly have no idea which drug will be best for me or not. I had the question, which one, the first time I was with my diagnosis. Okay, now you need to choose between these three medications. I have no idea. So I was feeling proud because they were asking me as a patient to decide on my future. How can I decide on my future? I just learned about a disease that I didn't know anything about, and now you're asking me to decide. So this is something, a funny fact on my patient story. But another thing, for me, is the same. There is this hierarchy. Even if they are invited you as a patient to participate, they know. I mean, I was pretty sure that moment when my neurologist showed me these 3 drugs, she knew which one it was the one, because
So
at the end I
it was a
didn't have
fake
the
choice.
But just to tell you an anecdote of what happened to me once, the drug I'm taking at the moment, okay, you are changing, you are having a new treatment. So the neurologist decide you are going to change for this treatment. Okay, I will go. I go to the pharmacy. And the pharmacist told me, so that's when the government is involved in the decision. I showed the prescription, and he said, this drug is not allowed in France, yet. So I said, what's happening? So my neurologist was so in advance, so that the drug will be allowed in 1 month. So you need to wait 1 month. So I am a guinea pig. I will be the first in France trying this drug. So I didn't decide. So the neurologist decided. And then the government decided that I needed to wait 1 month to have my pill. And I just, okay. And then I understood that maybe I was a guinea pig.
Yeah, in Peru we eat the guinea pigs. It's not good. Francis.
So I guess I'd give a slightly different answer because I think it depends on context and professionals' roles. So for instance, if a patient goes to see our heart failure liaison nurses because they've just been discharged from hospital after being diagnosed with heart failure, from the heart failure nurse's point of view, their task is to up-titrate people on their heart failure medications. So for this basis of doing that, I think if people come to see me, and in general practice, a lot of the ethos is a bit more about saying, well, what is it you've come here to see and what are your priorities and goals, although that doesn't always happen. Sometimes somebody seeing a pharmacist who's looking at like diabetes care or something like that may be quite focused on hemoglobin A1C, and it may be that priority, but it will vary, I think, depending on specialty and context, who seems to be prioritizing.
So the assessment of care, if it's directed at figuring out if people are getting good or better care than before, for instance, an assessment of the quality of that care requires understanding what care is and requires understanding what we value in it, right? And so it sounds from the answers that who gets to decide what care is could go from this patient with this clinician to this patient with all the clinicians involved in their care, to all the clinicians involved in the care of patients like this, to the health system within which these clinicians work, which includes not only administrative people, but people responsible for quality and also people responsible for paying for that service, if I may. So there are multiple levels of decision makers that determine what is better and then probably determine how to measure it. Maybe we can start there, getting to our topic of assessment of care. What are ways of assessing care that you really love, that you're really into, that you're like, yes, this is the way of assessing care that I really like? Who wants to start? Grow. You have the thing that you really want. Still.
I really want this, and it's not happening. So, and I have never been able to test it out. So maybe someone here can help me. But as I said, patients have a clear idea of what matters to them. You won't get what matters to them by asking them directly, what are your goals? But most people, if you use your communication skills, you can tease it out. Especially if there is a trusting bond there, you can tease it out what matters. And then I'd love to see that those key issues for the patient is part of assessment of care. You know, that they might be only experience measures, but most people have clear ideas of what they need their health for. Health is a resource for life. It's not a goal in itself. I need my health so that I can play with my grandchildren. I need my health so that I can be at work. I need my health, and I'd like to see that, especially for long-term chronic conditions, that we revisit those goals and that professionals have a conversation together with the patient. You know, what is working to help you reach those goals, because what health is if you have health challenges, that's an obstacle to leading your life. And so another of my aha moments in working with patients in assessment of care was that when I asked them what mattered or what was most important in their care, they would talk 90% of the time about the self-care, self-management, the work of care, how I fit it into my everyday schedule. And the health professional part was just tiny. And I imagined that I was so important. I wasn't. We weren't. What mattered was, how can I live with this well? And we don't, I can't see that healthcare is systematically adding that evaluation to our goals for care. And I think that, yeah, we have these three roles: the patient, the professional, and the system owner. And I believe firmly that if we were able to do this more systematically, the quality would be better, our professional goals would improve, and I even think it would be cheaper.
Yeah, so I'm hearing echoes here of that quality of, that care of good quality is care that makes a difference in the patient's life, that is mostly playing out in the patient's life rather than when the patient interacts with the healthcare system. And yet, most of people that are interested in the quality of care are interested in what happens in the healthcare system. Is that that's the key thing that you are pointing out,
Very
Guru?
good, succinct
it.
summary. Yeah.
Okay, so that creates a little bit of a tension, you know, and then you said, oh, I wish I could have it, but I can't. Mm-hmm. Okay, and historically you have not been able to do that because there's so many patients and so many moments in life that it's been difficult to manage that amount of information. So it's much easier to ask on the way out, hey, how was your experience today? And you just press one of those 5 buttons as if it was the bathroom in an airport, right? So that is an important tension. We're going to come back to it. What's your dream way of assessing the quality of care?
Okay, so I guess I'm going to be slightly controversial and say I have no dream measure, because I think patients think a lot of the measures we have don't measure what's important to them. So when we do trials of people with multiple long-term conditions and we ask them, what do you want the outcome measure to be? There's quite a lot of dispute because they look at a lot of the measures and say they don't really think any of them are good, so it's the least worst measure. And actually I was very impressed with a trial one of my colleagues did where they, for people with long COVID, where they actually had the outcome measure, that everybody had a different outcome measure. It was the outcome that mattered to them.
To each individual? For
each individual in the trial. And actually, I think that's what we need to think a bit more about. How do we tailor? We've got all these fantastic AI systems and things, and surely we can be much more personalized than just saying, oh, it's, you know, this quality of life measure or that, because I think people vary in what matters to them, and actually we're really lacking on things that measure that well.
And there's a history in physical therapy, I think it is, where if you go in for a shoulder injury, you don't get a battery of questionnaire about your ability to walk, right? Unless you're walking on your arms, right? And so you get about, you know, a battery of questions about what you normally do. That's not your shoulder, this one's shoulder. What do you do with your shoulder, right? And so you end up getting a battery of questions about your shoulder, and then you get better if those things get better, you know. And so if you also twist your ankle in the process, that won't be captured by the therapy that's directed by the shoulder. So there's a tradition in medicine to do that, but it hasn't been extended to other measures that are not physical.
Yeah,
yes, Professor Bob.
Well, just to comment on that, I think if things aren't psychometrically sound and developed in a way, then it's very difficult to actually bring these outcomes together. Other there may just be chaos. Like, I'm doing better. Okay, well, so I think there is a balance between, you know, the assessment which, you know, balances the burden of care and the benefit, and how do we measure that in a way that we can then look at it across people And it would be nice if it was like we didn't have to do that, but I actually think we do have to do that. There needs to be some bounds to this.
So the psychometrically sound outcome measures tend to also be fairly long and laborious and often irrelevant to the person answering those questionnaires.
They can be.
Does that
Well,
bother
think
you?
about your physical therapy example. I've had physical therapy. I usually hurt myself doing daft things with my kids, or just falling off bikes. But there is objective measurements that they are doing with me for. Like, I hurt my neck and I couldn't turn my neck very well. They measured how far I could turn it, and we were doing treatment. They would measure how far I was getting it, and they were also thinking, like, how do you feel? I'm like, oh, it's feeling much better. And we can see objectively, like, you're getting a better rotation. That's like a sound, objective measurement in line with my contribution subjective to how I feel. So I think that combination works very well.
It's a combination of objective and subjective.
I did use the word subjective, but
You did use the word subjective. I heard you say that. Yeah. Group.
Yeah, I just wanted to comment on that because I didn't say anything about measurement, but I do think that there are questionnaires where patients define what are their main health barriers, and then they, on a scale from 1 to 100 or 1 to 5, how difficult is that barrier for you? And then you measure again, and then you can see that for that barrier, it either is better or worse, and they are validated and all of that. The challenge with those, because the patient is invited to describe themselves what matters, what is the health challenge. A lot of people who are, if you're cognitively impaired in some way, that becomes a challenge.
Sure.
So for that part of the population, that doesn't work. But I do think that there are this is called the patient-generated index, but there are other metrics too that allow the patient to define what is important.
Paola, you get the last word before we go into a break in the function of the panel to actually get to hear from you, and then we come back to the panel for the second phase of this. So, Paola, what's your dream?
It's also, for me, it's also about the challenge is to not make this medical part of life of the patient a nightmare. So that will be great. Okay, I have my consultation. Okay, I can go. That's not a problem. I'm leaving my consultation with a prescription that I need an appointment for during 1 year or 6 months for an MRI. That's the nightmare. Having the appointment in France is a nightmare, but I think around the world it's the same thing. So that's the part that as a patient we love to not experience, because that's the bad part of the thing. The consultation with the doctor is fine. I got my consultation, and as soon as I'm finishing my consultation, I know when I am meeting him in the next months or years. But this little part, like, and go and leave yourself with trying to find that MRI. That's a nightmare, as you were saying. That's the challenge. So as patients, the assessments of care that will be not create nightmares for the patients.
So the no nightmare index will be your dream. Excellent. So we've gone to the first 45 minutes of our panel. We've gotten a sense of what they think care is. We've gotten a sense of who gets to determine what's better, and we have heard what their dream assessments, sort of the direction that they will take. I know we haven't gone in depth, but we've gotten some. I wonder about you. What are you thinking? What comments would you like to make at this point? And keep the comments brief. And if you want, if it's not a comment but a question, tell me who in the panel you think you're asking the question to. We have one comment here, and we have another one over there. So we can start there. And we'll do this for about 7 minutes or so.
Thank you. My name is Jasper, and I have a question for Gru, or do I pronounce it well? So you say most people know what they want, but it's hard to ask them straight away. So how do you help people articulate what they want?
So I work with a team of very talented care professionals, cross-disciplinary team that has worked a lot on this, especially with patients that are multi-morbid and they're really, really ill. And you'd think that these people would not know how to answer this question, because it's knowing what matters to you is not something that you just rattle off. Neither can I do that. And what they tell me is that they start with the small things. What do you think your day will look like? What would you wish to do today? And then they, gradually understand, who is this person? And I think the what matters to you question is it's not a method, it's a concept. And that people with communication skills, they figure it out. I don't want to give a recipe how to do it. I think it's part of the human condition to understand where your other partner is in their life and what they're willing to share with you. And it's also a huge matter of trust. Telling you what matters in my life is giving you also part of my vulnerabilities. And you might not ever get there, but we still have to be open and listen and try our very best. So sorry, I can't give you a recipe, but I think that a lot of people are able to ask that question, as a concept and actually get it if you're open to that idea.
So Guru, you just did something terrible. And that is, you gave away the secret, right? So in this conference, we talk a little bit about shared decision making, we talk about assessment here and so forth. And the secret of those things is that those things by themselves are actually probably not that helpful. It's what you find out, you discover, how you connect, what they enable to happen to make a difference in the situation of the patient, right? So even the act of being curious about what matters to this person, no matter how you ask, like you said, and then listening carefully to figure out who this person is, that is doing a lot more for the quality of care than assessing the quality of care itself. So there's a little bit of a judo thing where you're taking the energy of the measurement but using it to actually further the care. So now we need to get rid of you because you've given up the secret. So. Yes, Mike.
Hello, Mike Gianfrido, Care Unit, Mayo Clinic. Lots of comments, but I'll contain myself.
Yeah, you just had to get one.
But you just kind of stole my comment, which was the thought that I had was, at least in the U.S. and I think globally, we have many assessments of care, and in my opinion, many times these assessments go into a black hole. They go nowhere. They do nothing. And so to me, I'm thinking about, how do we make assessments, to Paul's point, right, that are psychometrically sound, but also are useful and usable, and they create change in the way that we care or help make people better. So I'll contain my comment.
Yeah, so the point I think that you're raising is that a lot of our systems decide that we need to have assessments, they implement the assessments, and then those assessments do not contribute to make anything better for the patient or the clinician.
Can I quickly comment on that? So I think this is the exact point that it's unethical how we use assessments. Like I was speaking with an orthopedist at Dartmouth, and they were asking for help with adapting a survey, and they said, well, some of our patients fill out thousands of surveys a year, thousands. I said, what do you do with the data? No, so they just do it. And with people who do PHQ-9 depression screens, no one ever tells them what it means. They just fill it out and it disappears, and they don't know, do I have symptoms of depression? I don't know. No one's giving me any feedback. It's just really useless.
And it's so sad when you mark that you cry every day all the time, and people go, your score is 10. Like, yeah, but I just told you I cry every day. Your score is 10.
My sympathies are with Francis, because I think the interface between research and practice around this topic is so chaotic, and we spend our life measuring things that don't matter and get lost. And I think that it's where and it's also the meeting of quantitative and qualitative. And the default position is always in research to want to have something quantitative. And I think you can only describe or assess care by a qualitative method, because otherwise you're not really listening to people. And my definition of care is being listened to.
All right. Anybody wants to comment on this?
Yes, I agree.
Yes.
No, but well, hold on. You don't get so easy. So we've heard psychometric measures, tracking over time, and that thing doesn't comport in that way. So you can agree, but how you use it?
I think it's sorry, go ahead.
No. I believe that the clinicians and the patient, if it is a long-term relationship or a long-term journey, we should have those qualitative assessments systematically in the medical record. Today we looked at what has happened the last year, what worked, what didn't work, and how can we learn from it. I think those are conversations that are absolutely essential, and I'm sure some clinicians do that, but I'm not sure that patients don't at least tell me that it's done systematically.
But what about at the health system
is the
level? What
quality.
about the health system level?
As soon as you systematize, you stop listening, because you're working to protocol, you're working to someone else's expectations, and you stop listening.
And so the moment it goes beyond that relationship to have somebody else assess, because they want to assess the quality of care, you're saying even if you do use narrative, the narrative itself will be systematized in some way, right? You have some, sentiment analysis and things like that.
Yeah.
Paul, and then we go to Paola, and then we go back to the audience.
Yeah, that narrative feedback directly for a clinician, I think, could be very helpful to hear, a patient saying, I really enjoyed our visit today, and the clinician saying, I really enjoyed you as a patient today. That can be very rewarding and develop that relationship rapport. But I think we can't discount the value of the quantitative assessment as well, because it's that's how we can also identify disparities, and it is a complicated relationship, of course, but it can highlight where there's ineffective, again, how do you define care, but it can highlight some challenges that we need to then, I often find with quantitative work, it gives us just a kind of signal to where there could be an issue, but we can't really understand it with that. So then we have to do a deep dive with more of the qualitative work to understand what that issue actually is. And so when they're used together, I think it can be quite helpful.
Okay, Paola, and then we go back to the audience. I know, Guru, you have your finger up, but we'll have to hold it for a second.
Remember, I'm Mexican, so don't be scared about what I'm going to say. You were mentioning quality targets, so something very important for a patient, and now I am trying to focus on finding doctors younger than me. And that's the problem, because studying medicine, it takes a long, long time. My doctors are dying, and that's what I said, I'm Mexican. So we are all going to die, but I need my doctors to be with me as long as possible. So if they die, who is going to replace them? And that's even if I'm trying to make it funny, that's a fact. And all around the world, we are missing doctors, and we are getting older. We are living longer now. So this is also a very big problem that we are facing. And so now, because my gynecologist died, I said, oh my God, and the dentist, he's in retirement now. Oh my God. So now I'm trying to focus on doctors younger, very much younger than me, because I want them to follow me until my last days, because I don't want to have this nightmare when I will be 60 or 70s or 80 trying to find a young doctor. So that's something very, very important to think about, this quality of health and care. I don't have the solution, but...
My mom has an exact opposite idea when it comes to who flies planes. Wants to have that. So we have several hands up. Let's do it very quickly. So Let's run to Zoe. Is it Kasia you want? Yeah, Zoe, Kasia, and then, sorry, I don't know your name. Sorry? Gretchen, and then we finish with Felipe. So let's actually collect all four, and then we'll get the panel to respond. And then we'll do Felipe and Maria, and then we get the panel to respond. So 5, real quick, Zoe.
Okay, so how do we assess and think about care in the context of preventative medicine when, because by nature, preventative medicine should be equitable and systematic, and what matters to the patient with chronic and multiple conditions or low socioeconomic status might be just what's happening today, not their health in the future. So how can we put the care into preventative medicine?
Very good. So suffering reduced in bandwidth, and so cannot think about Kasia is next. Marlene, Kasia is next. Might actually prevent people from seeing what's better because they're short-term connected. Kasia.
Thank you.
We'll charge you for the microphone. Yes, go ahead.
This is echoing some of the things that I've heard here, but I think one fundamental question is, one, what is measurement for, and who is going to use the measures? I think we're circling around this a little bit. Some measures, some quantitative measures, Paul, to your point, can be used, for example, for systems to allocate resources, right? And some measures may be used by me as a clinician to learn to do a better job. Some measures are also used to kind of rank clinicians. Maybe I want to see this clinician because they have 5 stars and this one has 4 stars. So I think we haven't answered sort of this question of like, why are we doing it, and then who is going to use it? And I think that's really important in this conversation.
So I'm sure that the panelists are writing down these things, and because we're going to come back to you to answer all these 5 questions. Gretchen.
Well, to piggyback on that, as a clinician and a patient, we have to deal with the Press-Ganey, Qualtrics, you know.
Yeah, they actually just got bought. They're one thing now. Yeah.
So you know what they look at is, would you recommend this institution? So you get your provider report, and it tells you what percentage of people say they would recommend the healthcare institution, not necessarily even the provider. And that's what the higher-ups care about.
Okay, so now we're into ranking like healthcare or care, like we rank restaurants. Michelin star restaurant, Michelin star care. Felipe.
Thank you. I wanted to bring to the table this idea of standardization that healthcare always goes back to feed this value of efficient processes, efficient caring, between quotes, right? And so, to me, caring is not only disposition and a practice, but it's also resourceful adaptation to our environment to provide the best possible assistance with the resources we have, taking into account values, preferences, etc. So, to go further along, Kasia's point is, should this assessment of care be pertinent to this adaptive values, and should it go further away from this value of efficiency that healthcare is always prioritizing?
Okay, so is there any meaning in measuring anything other than efficiency? Maria.
So this is turning into quite a complex conversation. I'm happy I'm not on the panel. So another round of reflections for you, maybe to pick up if you have time. So what would be the role of time in both what we understand as care and how we assess it, and also the absence of care? So I guess we all have, at least I do, and also in my research, an understanding of what care might be and what it feels like, and then by somebody removing it or somebody really providing care for you, you get more aware of what care might be. So there's something around the timing of when we ask people to reflect on care in healthcare that sometimes clashes or come into conflict with the urgency of your trajectory. So the role of absence of care in order to help us understand what care is, the role of time, and then I also feel that we are trying to put into words something that is a deeply embodied experience. So even though I love qualitative research, I'm not still confident that even with words we can really capture what care is and what it feels like. So just made some reflections.
Very good. So let's come back to the panel. I think that at this point. Thank you for your questions and comments. And we have several things. One of the prerogatives of the panel is you actually get to forget some of the questions you don't like. So, Frances, you have your hand up, so you get going.
So I'm going to start with the question about prevention. So I think prevention is obviously really important. We as clinicians think it's important because obviously it can prevent people getting their chronic illnesses, so there's that issue. But one of the things we don't think about, of course Victor's done all the work on burden of treatment, is that prevention is about burden of treatment as well, or burden of prevention. You know, when we ask people to be, you know, enacting a healthy lifestyle, or to be monitoring their blood pressure, or to stop smoking, or to drink less, all of that happens in the context that people live. And when you've got lots of, you know, maybe you have 3 jobs because you're trying to pay the bills, and you've got 3 children and caring responsibilities, fitting that in is difficult. So I think one of the things we need to be focused on is about, if we think these things are prevention, are there again having to take into account with people where they are and their circumstances, and how you support them, and what do they think is the most important thing, or the things that they can do. So I think this is much more, rather than us being paternalistic and just saying you need to do X, Y, and Z, and people go, oh yeah, that's a great idea, and nothing happens. We need to kind of say there's all these issues, you know, what might you consider dealing with today? And if it's none of this, as well, what would have to happen to enable you to be able to do that and to have those in place? I was very interested in the comment that made about who measures it for why and what are we measuring, and also talking about things that are missing and the absence of care, because I could bring those together. That we've a colleague in Glasgow, where I'm from, Andrea Williamson, has done a lot of work about missingness, about, for instance, people who miss their appointments, and those being the people who often have the worst healthcare outcomes, the highest mortality, the most hospital admissions and things like that. So we need to think carefully, what are we looking to measure and why? Because actually those people who are missing or absent from care are often those most in need of it. And again, it has to do with their circumstances, and trying to think about how can we help those people to be engaging with care that they need. They're often the highest users of services, so I can imagine, I could hypothesize that that would be a cost-effective thing. And so I think this access to care, it's that question about who's measuring it for why and for what purposes and what matters. Is what matters to us reducing inequalities in care? Is what matters to us improving quality of care for some or for all? Or is it, so I guess, and how is that data to be used? And do people understand the limitations and constraints of that data? Because I guess one of my problems isn't that all objective measures are all, psychometrically validated measures are poor, that people accept more meaning to them and put more meaning to them than is possible, and don't take into account their limitations or their problems and the buts, ifs, and hows that have to accompany them.
In fact, part of Iona's point is that they're actually often meaning poor, right? Because some of the meaning is actually made in the stories that people tell, like Ron actually simplified yesterday. Who wants to tackle some of these questions next?
I think sort of trying to understand how we got here with the number of surveys that are administered and why, because it just seems over, like, I have no health issues, thank God. I'm sure I'll get some when I'm like as I age, but I go and I still have to fill out probably 8 or 9 surveys before I can see the doctor, and I question whether or not did they get designed to just make the doctor more efficient, to put the work on me as the patient and remove the work from the clinician to simplify the visit, because if they don't see it, they don't need to talk about it, but then it's closing doors for conversation. And there's it's the risk benefit. The benefit is we could find something that we may not have gotten to, which is maybe a helpful thing, but the risk is if it's not filled out or not mentioned, then we don't talk about it, and then it closes opportunities for other conversations. So that idea of like purpose of measurement is so critical. And it's an interesting, someone mentioned the recommendation for the institution, the net promoter kind of scores. I remember reading this paper gosh, a decade ago, where they looked at the net promoter score from patients, but then they had the staff did the net promoter score for the clinic. and they found that the staff's impressions of their own clinics was much more predictive of quality of care than the patients. So we could just ask the clinic.
So it's just like going to the kitchen of the restaurant that you're trying to rate and kind of look at the floors and see if the cooks are happy. Good. Gro.
Thank you for all the good and wise comments that are coming here, and I think it's critical, as you're all saying, why are we measuring and how do we use it? It strikes me that there must be a wide variation of how much measurement is going on a regular basis in different care systems, because I don't recognize that picture that you're drawing of a lot of surveys that are sent out before the consultation and after. That doesn't happen in my system, and maybe we are under measuring and maybe you're over measuring. So that maybe can open the door for some comparisons. You know,
Yeah,
how is this working?
I don't think America is known for having the best healthcare in the world, so it may not be exactly the right approach.
But I wanted to comment on the question on the, you know, if we make assessment, qualitative assessment systematic, then it's worthless, especially if it goes upstairs. And I think you're right. I think that it's critical that this does not become a checkbox activity, and yet that we still are open to evaluation. So maybe it's something that patients have to bring up, that we open the door for them to do that evaluation with us or send them to us. And I wanted, it came to my mind there is a company, actually, private company, comes out of Australia that deals with care. It's called Care Opinion, and its mission is to be a broker of feedback to healthcare organizations. And so patients can go to their website, write in their feedback qualitatively, and that organization will then work with the patient. If it's a positive feedback, they'll send it directly to whoever they wanted to give praise. If it's a challenging feedback, they will work with the patient to make this as constructive as possible, and then they'll send it to that organization, and the organization is then requested to work with that feedback and respond. And the fun thing with that organization is they say 80 to 90% of our feedback is positive, and it's just wonderful to be able to give all that positive feedback back. And for the challenging parts, they also have multiple stories of how CEOs value those stories, and that they then can work with the system to change whatever it was. You know, look at it as system perspective, and also, you know, it gets directly back to the clinicians. And so I think we just need to be, I believe qualitative is important, and I think some kind of system for it is important, but I'm also very concerned, as you are, about not making it a checkbox thing. I also wanted to say that your story just illustrates how important continuity of care is, and it's a key challenge, I think, in every care system, especially as we get older and we collect all these chronic conditions and we see specialists for this part of our body there and a specialist for that part of our body there, and these two do not have time to talk together or read each other's notes. So how do we make sure that these two aren't in conflict? And often the patients tell us again and again, because the doctor doesn't necessarily have an insight into what that other doctor said, because they might be in different organizations, I'm the carrier of the information, and that's a huge burden on the patient, because both, I don't know really what matters to the medical part of the evaluation. I might be not telling something that's really, really important, and yet here I am, the only carrier of information between organizations. So I really believe information is power, and patients should be able to be supported in telling their stories by a much stronger information flow across care organizations that they visit, so that there is information support for the patient journey and not just the visit.
It's actually quite interesting you use information flow for stories, because our data scientist colleagues believe that the problem of healthcare is a problem of data, and therefore the solution will come in the form of Google or other kind of companies that are experts in data. And yet the thing that needs to be streamed, if anything, that needs to move through the system is those stories of successful cares or failed cares or the absence of care. And it's those stories that probably, if they are specific enough, might actually then lead to efforts to improve. That would be one purpose of measuring, right, is to make things better, and to train, other clinicians or even patients in self-care, like you were saying, Paola, information sharing, to actually be more effective. So it's not just data streaming, but it's story streaming. Paola, any comments on the questions that you?
I just thought about. Thank you for your last comment. That a lot of funny things happen when you have MS, and one of the funny things is all the other doctors will say what you are suffering is because of MS. So then it's funny because they don't think about it's really a problem. No, it's just because you have MS. You go and you talk to your doctor. No, this is not MS. You need to think about. So when you were saying this sharing of information, if I have been complaining, I have a pain here, it's MS, it's not MS, but you spend years or months visiting different specialists talking about the same little pain, and they are all just passing the ball because it's not MS, it's MS. It will be great, as you were saying, Gro. The patients, we will always use the same words. So if you are typing your report and saying, she has one finger is moving faster than the other ones, or whatever, is the way I will explain my pain, and the doctor is tapping this on the report, the other doctors will notice that she has been complaining about this little finger moving faster than the others. So when they are going to, you were saying, measure that this is a regular situation, because after visiting all, the conclusion is that just go and live with a faster finger than the others, because at the end it's not the end of the world. No, it's not the end of the world. But so it's very important that measuring how many, not how many times the patient will complain about the same issue, but how can we share this information, and how the medical professional can have this little moment to share. Okay, I am having Paola today. Okay, I can see that during the year she went to see this doctor and this other doctor complaining about the same thing. No solution. It's because it's MS, it's because it's not MS. So somebody needs to take action into this situation. And that will be also another, that is already a nightmare that we saw for the patients, like, it's not my deal, it's not my problem, it's not.
So that actually brings up another issue, which is this idea of, for instance, the value of teamwork and coordination of care, and so forth, particularly for people with multiple chronic issues, either known or unknown, right, as you were saying. Let's try to bring a few things together now. Recognizing that some comments, for instance, the one on time, and others have been elegantly ignored by the panel. What do we do with the fact that it looks like our panel has been infected by an industrialized mental model of healthcare? And what I mean by that, with a lot of love, is that all of you have used the word measurement, right? And I suspect if you imagine humans coming together to care for and about each other and to advance the situation of the patient, you will think of this poetically as adjacent to love, right? And then we will have a panel here about, how do we measure love? right? And who needs to measure love, and who's responsible for what happens if we find a deficit in the amount of love or the quality of, and it feels weird, right? Because one of our panelists should probably be a poet, and probably will get a lot of the insights. Why this obsession with measure? I want to understand the quality of the care. I want to assess it, and so that I can improve it. But does it have to be measured? Do we understand why we have this idea that if we don't measure, we cannot improve it? And do you use that in your love life? Go ahead. Anybody?
Well, I'm going to say maybe it doesn't need to be measured. Maybe it needs to be the word you used for the panel is how do you assess, wasn't it, or evaluate, which doesn't necessarily need to be a measure per se. But
which expands a little bit to Iona's territory. Yeah.
But I think you have so many measures because policymakers or health systems look at how much does something cost and how many widgets can we get through the system.
So somebody's managing.
Yeah. And there's these external pressures to be cost effective and to get the most effective in terms of the most people through the system or meeting certain observable, the tyranny of the HbA1c, people have that done, or their blood pressure or X or Y or Z, which of course there is some reason for being interested in these things in terms of final outcomes, but sometimes an obsession. In the NHS, we like to say the time till you first get seen, but we don't care about the fact that after you first get seen, you might need a whole lot of tests, and it could be 2 years before you get seen again. They don't measure that, so we're not interested. For the patient, being that first time you get seen matters, but it matters just as much what happens right after that, and yet we don't care about it, or there's a lack of.
And it's a competing, it's an opportunity cost, right? Yeah. If you do have a lot of measures, that will capture your attention, and you will try to improve this, and then all of a sudden you forget to have the conversations. Guru, you have your finger up again.
Yeah. So you were talking about love, and I'd like to quote Don Abedia, and I'm not sure it's the exact right quote, but he says, at the end of the day, quality is love, and you work backwards from there. And I think that depending on your role in this care system, you're a patient, you're a provider, or a frontline worker, and you're a system owner. I think the system owners need measurements. There's one thing that we haven't talked about here, and that's equity. And equity requires measurement, that we are actually serving the populations, like Mina talked about yesterday. Are we serving the populations that actually need us, and could we serve the populations that already are healthy and well-to-do in less resource demanding ways? So measurement is key at the system level. I'm convinced of that. But at the frontline level, I think qualitative assessment, it's not measurement, it's a qualitative, and it's somewhere in the same, as an act of caring is an act of, I hesitate to use the word love, but
just use it.
It's something close to love. And it has to come from the heart. It has to come from, and of course, you can't love all your patients. That's just impossible. We are human. Healthcare professionals are human. But I do think that my healthcare professional colleagues really care. They really want to make a difference. They really care for their patients. So helping professionals care for themselves is perhaps essential for them to also be able to care for others.
It sounds like another dimension of assessing care. Paola, and then Paul.
Somebody in the audience.
We want measures. We want measures all together.
No.
Now the thing is, why do we need measures? Even when you were saying, when you are going to the airport, to the toilet, and you have the happy face, this is measuring something, even if it's not only numbers. Even if we start hugging, I love hugs, how many hugs did you have at the end, did you got from your patients at the end of the day? So you need to measure. I remember when we were on COVID, And I was shocked because the people wanted to go back to normal. And I said, that's the only thing I don't want to live again, is to go back to the way life was before, because that's mean that we did a lot of wrong things. So if we can avoid these wrong things that we did before, and that's why measurements are there, that will be great. But we need to use them, and we need, as you were proposing, we need to measure the good things on a good way. Not just measure for measure, but measure to apply for change, to create a difference. Okay, what we are doing right now, how many doctors are being kicked by the patients because the way they explain is not clear, or they are being so aggressive that they get aggression in response. So that's measure, but that's not very helpful. So we need to measure. I mean, we want, because we want things to be changed, and change for better, change for good. So not just because we want more money, or maybe we all love
Cool.
So I think measurement's critical, and it helps us with our blind spots. I think that the challenge today is that it's like we've committed too much of a good thing, where like Florence Nightingale developed measurement back in the late 1800s and was able to find where there was clinics where there was much higher rates of mortality and morbidity, and that allowed opportunities to improve quality of care and better care for patients in those clinics. However, I think we've got to a point where we are over measurement. And it's for no real purpose. It's like, if you think of a map, you know, if we come to Paris, and if you have no map and someone says, well, let's go to this nice restaurant, you're like, well, I don't know how to get there, I have no map. And so you get that basic map, just street names, okay, well, I can find my way, I think. But if you said you want the most detailed map, well, the most detailed map would be Paris. So then you'd be standing where you are lost again, and I think that's where we find ourselves, with over-measurement to the nth degree, to the point that we may as well be sitting in the visit and we can't do that. So how do we try to bring it back again? But I don't think that solution is we don't measure. I think that would lead us into blind spots again.
So what have we heard? I'm sure everybody has their own summary. And if you look at the structure of our sessions, it's actually purposefully designed to continue this conversation into lunch in a few minutes here. And so I am glad that we're leaving this panel at a stage where, like, oh gosh, what is it? And how are we assessing, and why are we assessing it, and who gets to decide what is it that we assess and how we assess it? Who gets to decide if it's a metric, if it's a psychometrically valid one, if it's a story? Who gets to decide what is presented at the board meeting, and for the leaders to see whether it's a dashboard with numbers, or it's the story of a success of care, or a nightmare, or the absence of care? And who decides? And then to what end? One thing that I think it's become interesting is the idea of purposeful assessment of care. And one thing that I would love some of the conversation at lunch to focus on is how do you position care? Because some people think of care as something that is delivered, as in there are boxes that are available to me, and I'll pick one and just give it to the person that seems to need the specific kind of box, and we can measure that process of identifying the box and giving it to the person. And that will be a judgment on the clinician ability to identify the right box and deliver it perfectly the first time. That's one imagination. The other imagination of care is something that patient and clinician co-construct, that patient and clinician co-develop, that emerges from their interaction as they struggle to make the patient situation better. And in that setting, when you start, you have no idea where this adventure is going to end. So how do you know exactly how to measure what happened or how to assess what happened if you don't know what this adventure is going to be about? So there's another, I hope that you get to discuss this in lunch, is do we think of the patient arriving at this center and the center responding with a clinician? and the patient assesses how that response was? Or do we imagine care as something that emerges from the interaction of two humans that are served by this system that creates conditions for these humans to come together? And there, the assessment could be, did this institutional apparatus, did they create conditions that are favorable to care? And we get to hold those institutions accountable for creating the conditions of care, rather than holding the patient or the clinician accountable for the care that they were able to create. So that's another shift in the focus that I may want you to consider. So at this point, I want to do two things. One is, I would like you to join me in thanking our panelists for a wonderful discussion. They're very approachable. Feel free to approach them at lunch, have in-depth discussions, particularly if you didn't agree with anything they said. That is particularly helpful. And then at 1 o'clock, so lunch is from 12 to 1, so it's already 12:01, so I'm taking 1 minute off your lunch. At 1 o'clock, there will be 4 groups. Think of them as little expedition forces. There will be 4 groups that are going to be led by those people. Felipe, you raise your hand. He's in the back. If you're interested in burden of care, Felipe is going to lead a group that is going to go through those posters that are numbered there, that are focused on burden of care, and focus the discussion around those topics. Group number 2 will be Mike. Mike's over there. Raise your hand. And those posters deal with care that fits for older adults. And so Mike will facilitate discussions around those posters related to that topic. I'll take care of group number 3, implementing care that fits. And Casey over here will be taking care of group number 4, care that fits in unique populations. So, of course, you can go through the posters on your own. Of course, you can ask questions and interact with each of the poster presenters. Or you can join the group, a group that you like, and we can go around as well. The point is that in many places you have a poster, you stand next to your poster, and nobody comes around to talk to you about your poster, which is super sad, because I'm sure you have great things to say, great things to comment, and great things to learn. So either join a group or do it individually, but visit the posters. Lunch finishes at 1, posters start at that exact time, and I hope you have a great time. Thank you again for your attention.